Yeah, I got my QI project meeting from 8 to 9 this morning.
Morning to everybody who signed on early. We'll get started in a few minutes. Give folks one more minute. I'm wondering, well, at least here in Northeast Ohio, we are having a lot of fog. So I don't know where everybody else is, if you're all experiencing fog as well. So might be slowing people down. We'll give a, hey, what do you think, Andy? 802?
Yeah, and give people another minute.
I'm trying not to take it personally because I know sustainability and overcoming barriers is such a hot topic. All right, Andy, why don't we go ahead and get started? So welcome everybody. I'm going to go through these slides relatively quickly because I think you've seen them all before. This is just about cardio and what we do. Just a reminder, it's an initiative of the 7 medical schools across the state. And we're here to identify and produce and disseminate evidence-based cardiovascular and diabetes best practices in primary care. And we have a whole bunch of resources, including that are available at cardio.org, including newsletters, podcasts, webinars, and quality improvement, which is what we're all doing here in this Project Echo series. So welcome. So I'm going to go through an introduction. We'll go through the didactic presentation. Then I will turn it over to Gotham, who will do the clinical pearl and the case study discussion. Amanda will facilitate the site report outs, and then Andy will tell us what we need to do next. Just once again, a reminder, these are the 6 participating sites. We represent the state. Thank you again for participating. Excited to have you all here. These are your leaders, co-PIs of Cardio overall are Mike Constant, Sherry Bolin. Both of them I facilitate this with Amanda, and then we have our amazing project management staff that we could not do any of this without. So thank you, Andy and Claire. We have no disclosures. If you want CME, email Andy or chat her during this clinic, and then you'll automatically be opted in for all future clinics, and you just need to complete it by January 5th. If you don't receive an email, you can contact Kathy. And then if you're family medicine, you can get maintenance of certification through the ABFM website. Remember, please do not share any PHI. And if you can, turn on your cameras. We'd love to see your faces. I can't see everybody in my Hollywood squares, but love to see your faces. I understand that some people might be driving or some people may not be camera ready at 8 o'clock in the morning. But if you can, that would be great. So today we're going to talk about overcoming barriers and sustainability and quality improvement. So we're going to start by examining the AHRQ sustainability model, which is just one sustainability model, but it's one we use quite a bit to understand what components are necessary for a project to live on after the initial funding spotlight ends. We're going to talk about why projects, we often talk about why projects don't start, but today we're really going to address 3 barriers to successful completion rather than initiation, and then list a minimum of 2 strategies to sustain quality improvement. So it's something that we shouldn't really think about at the end of the project. It must be baked into the design from day one to avoid retrofitting later. And we have to kind of look at this as a long-term journey, several years sometimes, to really see sustained results in primary care. Next slide. There was this article that came out a few years ago that talks about culture of sustainability in primary care. And we think about it in they thought about it in a couple ways: foundation and implementation. So sustainability really begins with a commitment of time and resources. It shouldn't be extra work. It requires redistributing income for leads, hiring dedicated analysts, and ensuring teams meet regularly. You really want to appeal to team members' intrinsic motivation. So you want to frame QI as an improvement and not a mandate. Focus on what staff and patients really value to leverage their national passion. And like I said, you've got to think about this as a long-term journey. And you want to involve patients in these in co-designing solutions. So in this project, they had 36 patient advisors engaged, and they improved after-hour access from 56% to 79%. You also don't want to start with the hardest problem. Pick something that could be an easy win. They picked cancer screening improvement, which demonstrated that improvement was possible and really helped to build staff confidence. And you want to welcome criticism. We often hear that data is wrong. This should really be an invitation for a dialogue to accept that data doesn't have to be perfect to be good enough. Next slide. They also suggested learning from failures. So not every project will succeed. In fact, many, many, many don't. And I can say from having done this for a number of years, and I'm sure Gotham and Sherry are on the call, they can say we've learned a lot from our failures. And it's okay to drop a project if no progress is made, or take a break and renew it. They did that with flu shots, which makes sense because it's seasonal. And that helps you adjust when things don't work. And QI really shouldn't be a side project. It should be integrated into operations with quality improvement directors on management teams, and quality improvement as a standing item in staff meetings. And you want to move from thinking about it as a project to more of an ongoing monitoring, and integrate data into daily workflows so you're continually watching your core indicators. Next slide. Okay, so when we talk about sustainability, we can't sustain everything. So we must choose the elements that have high impact on outcomes and organizational value. You can redesign clinical workflow. Redesigning clinical workflows should really be baked into ongoing staff education and onboarding. And using data dashboards and governance frameworks to maintain oversight even after the intervention period has ended. And you really want to plan for these key components early so you know exactly who will own them and what resources are needed. Next slide. Okay, so you really want to design for integration. So what this means is really like embedding it and not bolting it on. So sustainability often fails when we create parallel systems. We have to embed the components into existing clinical and technological structures, such as the electronic health record. And we need to try and eliminate redundant processes. If a QI task creates a parallel system that doesn't talk to the electronic health record or something that's already built into your workflow, it most likely will eventually be abandoned. And capacity building, as boring as it sounds, is all about redundancy and building in like a lot of repetition. So, for example, we always talk about, not having the project rely on one person, but it could rely on one role. So if you have one person who does all of your, knows how to run the data, and that person leaves and you haven't cross-trained people, the project will probably die when that person moves on. And then you want to align your project with institutional priorities, such as patient experience and safety, because it will feel more of like an adoption and be more likely to be adopted than a disruption. And then you want to transfer ownership from the project team to operational leaders. And these executive sponsors will really help play a key role here by providing strategic alignment needed for long-term success. So when we talked to you about like when we recruited you, like having your leadership buy-in was really important. And we talked a lot about that during recruitment and the initial phases of this project. Next slide. Okay, so ownership and governance is really important. So you want to have a designated clear operational leaders to ensure the accountability beyond the project period. These executive sponsors, and once I mentioned before, they're not just for signing off. They really help provide the strategic alignment that builds long-term success. And you want to utilize existing boards. So rather than creating new meetings, you want to use existing committees like quality improvement and safety boards to monitor performance and guide any necessary adaptations. And then after the funding ends, the governance doesn't end when the grant does. These, you need to really continue to monitor metrics and refine workflows even after the active funding period's over. And then integrating into management. So to really bake QI into culture, the QI director or who's ever in charge of quality improvement, whatever their title might be, should have a seat on the management team. And this ownership is really reinforced when QI is a standing item on every staff meeting agenda, making it a core part of the institutional strategic plan. And the governance is really also a safety net for the project. If the metric starts to slip, if you have a governance structure, they can ensure that somebody notices and has the authority to intervene. Next slide. All right. So here's a couple of ideas about how you could do capacity building. We talk a lot about train the trainer. So you really want to distribute expertise across the organization using this train the trainer model. So for example, in this model, we've really tried to build in coaching capacity to help you all so that you're not just relying on Amanda or me or Gotham to talk about QI coaching, but you have your clinical coaches who are working with you. And you really want to onboard, when you're onboarding people, you want to orient them to the new workflow during the orientation. Because if you're not building that redundancy in and there's a lot of turnover, your process and projects are going to die. And then you want to empower local champions to maintain ownership and keep the team engaged at the frontline level. Next slide. So the most common project killer is the end of a grant. We really need to incorporate these costs, program costs early into department budgets early so that when the grant ends, you can continue doing the work you do. And you really want to look at ways to use existing staff and infrastructure more effectively to minimize new expenses. External incentives. Align your financial strategy with reimbursement models or accreditation requirements to ensure that the work pays for itself or is mandated externally. Next slide. You can't track everything. So, and makes it, a lot of teams really want to track everything, and that makes it really impossible to maintain your project. So you want to pick a set of small, high value metrics that are feasible to collect for the long term. And if you can automate them and use low burden automatic data systems or sources like the EHR to reduce manual effort of reporting, your project's much more likely to be successful. And then you want to review your data routinely. And that depends on obviously what your outcome measure is, to ensure that you catch any sort of performance drift. And then obviously give feedback to your teams, give and your leaders to engage them and help drive continuous improvement. Okay, so then we have to talk about scale, spread, and adaptation. So when spreading an improvement to a new site, you have to identify what components of the intervention must stay or must be adjusted for local context. So one example is like if you're, we've talked a lot about blood pressure and blood pressure monitoring, not just in this QI project, but throughout cardio. And we know that there's specific things we need to do to check blood pressure. But if the physical structure of the building doesn't allow for somebody to sit for 5 minutes before their blood pressure is checked or after they've walked in, you need to think about those internal processes and how you're going to adjust for those before you do a blood pressure check. And you want to create process maps and implementation guides to make it easier for others to adopt your work. So we have a lot of guides that we've used as part of cardio, as part of a lot of the work that we've done collaboratively to talk about how you might do some of the work that we've done and make it easier for you to adopt. And also, more importantly, ding, 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 learn from our failures. And you want to use peer learning and cross-site share outs to foster a culture of collaborative improvement. So that's what this is all about. We're all sharing what we're doing. We're learning from each other's successes and challenges and giving feedback, because if somebody has a challenge, another team might have a solution or some thoughts about how they've addressed that challenge. So those are all really important things to keep in mind too. Slide, Andy. So during the active funding period, that's where the heavy lifting occurs. You embed workflows into EHR integration, and you're building staff capacity during the early funding. And before the funding ends, you have to really shift that operation to operational leaders and budgets to be managed so that you know how to move on and whether or not the project can be sustained. And then post-funding, the governance groups will really continue to monitor metrics and plan for future adaptations. And the mapping of this timeline is really the hallmark of successful quality improvement projects. Next slide. All right, so this is my acronym from the IHI's Framework for Sustainability, MOCA, hence the cup of coffee. So you want to ask yourself these types of questions. You want to address measurement. What are we going to continue or stop measuring? What is the response for negative signals? Who's going to own it? And are they engaged and on board? How are we going to communicate the change? And oh, that's a staining. It should be training to support this. Obviously, nobody got that typo. And then hardwiring the change. How do we make it easy to do the right thing? And standardization and documentation of needs. And then are there changes, increasing workload? And if so, how do we decrease this or adjust adjust workflows and responsibilities? Next slide. So some common sustainability barriers are unclear ownership, grant-dependent staff, and lack of frontline buy-in when there's the most frequent gaps. Some of the mitigation strategies we can have include assigning owners, embedding processes and systems, all these things we talked about earlier, automating data collection. And then concrete examples demonstrate successful application of mitigation strategies to enhance sustainability. And I know Amanda's been working with you on all of these to help you really implement your interventions and think about sustainability. And then you want to identify risks early on, have continuous monitoring and collaborative efforts to ensure long-term sustainability and viability. Okay, I have one more, Andy. Yeah, so the key takeaways, start early. Embed sustainability from day one. Retrofitting later is expensive. And if it's not in the workflow system, it won't last. Clear accountability Operational leaders and budget strategies ensure project continuity, and ongoing monitoring really helps sustain efforts and responsiveness over time. Any questions or comments?
Thanks, Aleece. I just had a comment, and it relates to one of your early slides on the data is wrong and the whole issue of measurement. The data, just having had a chairs meeting yesterday, I think it was yesterday was Wednesday, where this issue came up, and it had to deal with time to first appointment, a measure of accessibility, and we were looking at the different departments, and urology was 40 days, we were 50 days, et cetera. And we all said the data is wrong. And you can come see me this afternoon. Why on earth is it 50 days? And I think it deals with that measurement issue of all things. People are measuring things incorrectly or in a way that is not commonly understood. So one of Aleece's points is make sure you understand it, that everybody understands what you're measuring and why, and have input into it. Otherwise, you will definitely get the data is wrong later on, and it's very difficult to change things because you've already analyzed data according to a specific parameter. So keep that in mind as you build your sustainability efforts.
Yeah, and just to add on to that, Gautam, we have lots of conversations when we're talking about data collection, about defining numerators and denominators and inclusion and exclusion criteria. So really understanding how things are measured are really important in quality improvement, not just for these projects, but for all those external measures as well, that, somebody will send you your data about what's going on in your practice or your hospital or your clinic. And really, you can't really draw any conclusions about that until you understand how that data is collected and everything that went into it. So that's why we have these long conversations about data, so that, we're getting it, it's never going to be perfect, but so that we have some, at least, as good as it can be, and consensus about what the data actually means.
True.
And I think I'm turning it over to you, Gautam, unless there's more questions or comments.
Any other questions or comments for Aleece before we move on? Let me scroll through. Okay. So we have a little extra time, and I do want to spend some time on the case, but I want to make sure Amanda has as much time as possible to do her segment. So the clinical pearl is going to be very straightforward today. So let's consider Evelyn, who's 53, has obesity, no diabetes, no other conditions, just obesity. Her BMI is 38.35. She's tried unsuccessfully to lose weight through lifestyle changes. She's enrolled in over the course of many years in commercial programs. So she's very typical. The average patient of this sort has lost and regained 12 to 1,400 pounds since they were an adolescent. So she's very interested in GLP-1 receptor agonist therapy, comes to see me or one of you, but it's an explicit exclusion in her health insurance plan. There's no way around that. She doesn't have sleep apnea. She doesn't have diabetes. She doesn't have heart disease. So let me start with this question. What would you consider? How would you respond to her request? Because she's got friends, she's got relatives, maybe her husband's on GLP-1 through his insurance, maybe her sister is. What would you say to her?
Hi, this is Amber.
Hi, Amber.
This happens to me literally every single day.
Yeah, me too.
I usually have the conversation that the medications in this class are, have been successful with weight management. However, they can be very costly, and I try to have the most honest conversation. Like, is that something that that patient wants a cost that they are able to take on? Some persons have FSAs and HSAs that can still help them afford it. I know that like Zepbound you can send the medications directly to Lilly, and they have a more affordable monthly cost for the patient. And some patients want to take that on and some do not. I do give them referrals to weight management providers. And then if they are able to, there's no contraindications for other medications in within the weight management class, then we discuss other options. So That's how I approach it usually.
Yeah, thanks, Amber. That's a great starting point, and that's pretty much what I will do too. So the discussion often proceeds. I'm sorry, there's just no way for this to be covered through your insurance. And then she might ask me, well, how much is it? I said, well, I mean, the actual commercial retail rate is $1,000 to $1,200 a month. And of course, for the vast majority of people, whether you have an HSA or anything, that's way out of their range. It's far too expensive. Lilly Direct has things, Novo Direct has things as well. There's a number of possibilities in terms of discounts and coupons, but usually the discussion comes around to compounded medication at some point or another. Now, this has gotten out of control. I'll talk about a recent article I contributed to, but there are people buying this out of vans on the street. One of my patients pooled her money with some other people in her workplace and bought some GLP-1s from a guy, and none of them lost any weight, almost certainly because there's no GLP-1 in it. They've wasted thousands of dollars. This is going on. This is out of control right now. So let me just move on. Next slide, please, Andy. Sorry. So we have a review in current cardiovascular risk reports. I'm one of the editors of that. Daryl Hewlish is putting that together. Also, in the New York Times, this is from February 21st. It gives you some advice on buying some of these compounded medications. Now, two key principles. Compounding itself is an FDA regulated process. In other words, how it's done. In a reliable compounding pharmacy, the one that I refer patients to, which is Butterer in Avon and Sheffield Lake, which is distant from most of you. It's the closest one to us that I rely on here in Cleveland, but many of you are further afield. But in Columbus, Dayton, Toledo, you have reliable sources as well. I think one of the most important things is have they been doing compounding for 50 years or 100 years or whatever it happens to be? That is a reliable source. But unfortunately, the actual impact of the compounded medication is not FDA regulated. In other words, the process is FDA regulated, but we don't know if it's actually going to be effective. But that's not a huge problem, because generally speaking, if the compound is reliable, it's often compounded with vitamins and a niacin or something like that. There's no reason to think that there would be an unfortunate interaction among them. So if you are looking at it, I recommend that possibility in addition to the choices that Amber mentioned as well. I think all of this is going to improve in 2027 when we'll see the first generic semaglutide and other variants coming onto the market too. So the cost should come down as more manufacturers and imports from India come through as well. So we'll see some changes next year. But for the time being, I think how Amber phrased the discussion is fine. And then when you get to compounding, follow the advice that's in this article, and our paper's going to come out soon. Okay, any questions about the clinical pearl?
Just go with them. When you plug in that article, unless you have a subscription, you can't access it right now, the NY Times one.
Okay, I'm sorry. I'll send, you know what, I can, I'm going to send it out. I'll send it to Andy later.
Awesome, thank you.
Yeah, and maybe she can send it out.
Gautam, this is an ongoing problem. To what percentage would compounding decrease the costs for the patient?
Oh, great question, Oscar. I wish I had a precise answer for you, because it changes all the time. Right now, as of March, last Friday, whatever that was, that's when I sent people to the compounding pharmacy. These people are so, Amber can attest to this, they are so enthusiastic. They are calling the place while I'm, wrapping things up and printing out the AVS, literally. And the price they quoted was $199 for 4 weeks.
Wow, terrific.
Yeah. Now that is a lower dose, the 0.25, and it goes up, but it only goes to 249 at the higher doses. So now that's not trivial, right? That's a few $1,000s a year. But for kind of a middle-class person with commercial insurance where there's no coverage, it's fine. But I've seen a lot of people on Medicaid willing to pay that amount as well.
makes it affordable for a lot of people, I think.
Yeah. And when we start to see the generics, I'm guessing late 2027, it's going to be $200 to $300 a month.
Okay. Thank
Any additional questions or comments?
I just, when we have milestones, when our patients make milestones, we do a standing ovation or like a clap out. And I have a patient that's been on the compound with this company. She started her weight loss journey. She was at 248 and she weighed in yesterday at 175. And just the way that has changed her entire world, it was very impactful to see. So I still believe in the GLP-1s. It's an ongoing conversation we have, especially about safety and efficacy. But obesity is such a hard chronic disorder to overcome, and when you see progress and the way it changed person's lives, it's really nice to see.
Yeah, keep in mind, as I'm sure most of you are aware, that there is a regain of weight if the GLP-1 or dual agonist, or there's a triple agonist coming out late this year. If it is not accompanied by significant lifestyle changes, the weight gain is extremely rapid as well. So either you continue taking these for the rest of your life, which most people probably don't want to do, or you start to adopt lifestyle changes early on, as soon as you're prior to prescription, which includes, the timing of meals and also increasing physical activity. Otherwise, weight gain will be significant. So I agree with Amber, they can be transformative for the vast majority of patients, but keep in mind the regain of weight upon discontinuation. Okay. All right, Andy, I think we can move on. So this is our case discussion, and has been the goal here is to think about some of the principles that Aleece outlined in her presentation on sustainability. So Joanna Helfand's QI efforts in her Cleveland area practice are well behind her anticipated completion date. She has spent considerable time and effort to institute smoking cessation counseling systematically. So there's two aspects here. So she's trying to educate the providers. She's maybe built an alert in the EHR. She's educating the staff about smoking cessation. She's put together something very simple in terms of coverage, and just a little worksheet that's everywhere on what's covered in terms of varenicline, counseling, the quit line, all in one sheet. She gives to patients and to providers, etc. And there's been some improvement, but people have said, okay, your project is now pretty much coming to a close. But based on what you heard, what would you do to both improve and sustain this particular effort that she's made?
Good morning, Dr. Rao. It's Jim from East Liverpool. So, one recommendation that I would like to suggest regarding this QI is that did Joanna communicate with? Of course, she did communicate with other residents, perhaps, or practitioners, perhaps. And in terms of that, what kind of, or should I say, their patient follow-up in terms of this one, because if the communication is clear, the education is clear, maybe their follow-up to the clinic is an issue regarding this. So I would like to, that's the first thing that I would like to touch base on. So what's our follow-up rate in this clinic? How are we communicating the timely follow-up for our patients so that we are able to document if the success rate of smoking cessation, for that matter?
Yeah, that's excellent. So, I mean, it's a basic process that is integral to this QI effort. So do we know? Maybe lots of people are quitting smoking, but if they don't come back and tell us, then we have no way of finding out. So that would be really helpful. So I think that goes back, Jim, to the measurement type of issue. Okay. Anything else that would be helpful in terms of sustainability? Okay, the only other thing I would suggest, and I know Aleece has talked about it, I've talked about it a lot, and that's engaging patients in the QI effort, which I really think as you know, in the age of AI, where patients have all the sorts of information and tools available to them, is going to be important. But maybe texting the patients in advance of their appointments, or at a certain point. I mean, Jim mentioned follow up, but they can tell us if they've quit smoking, right? They don't need to come into the office. So monitoring their efforts there, see how many people respond. A lot of people won't tell you if they've quit or not. So those kinds, that level of engagement, or asking them, what would you need to make this quit attempt more successful? It might be, geez, you know, I just need to get on medication, or I need more help, or I need more encouragement, or usually, unfortunately, it's my spouse is a smoker and I can't seem to get him or her to stop. But there's many different things. So I think engaging patients will be helpful. Any last suggestions for sustainability? Okay, well, thank you all very much. You know, I was supposed to go to the airport to go to DC in a couple of hours, but that's been canceled. So I guess after this, I'll go to the coffee shop or something for until tomorrow. So anyway, I'm going to turn things over to Amanda. Thank you.
Good morning, everyone. So today we're going to continue the conversation and talk about sustainability. So we've asked all of you to kind of put together some of the ideas that you have to continue to sustain your projects after, as we know, we're coming to a close of this project. So today we're just going to kind of talk through the ideas that you've come up with and how you've been putting those things in place as we've been working through this project to make sure that your projects stay alive and continue to sustain over time. So we're going to talk about how will we make it hard to do the wrong thing and easy to do the right thing, and then some standardization, and then any other ideas that you guys have would like to share with us. So we will start with Metro Health. Arpita, are you on?
Yes. Sorry, I wasn't sure if I was the first one. Thank you.
You are the first one.
So good morning, everyone. My project is about improving statin initiation in patients with ASCVD risk score over 10%. So for sustaining this project, I have few ideas that I would like to do is to incorporate the ASCVD risk calculator in the progress note as a standard automatic calculator, and with this going to be expanded to health maintenance in the future to eliminate any like clinician reliance on the clinician memory, or like, you know, that even includes like we have a smart set for hyperlipidemia that most of the physicians did not realize that's a standardized smart set, and I would like to train the providers to see if that is one thing that they can keep using it, which is based on evidence-based, and this helps to, like, you know, become a default rather than an optional thing for the providers. And using a standardized smart phrase for like a decision making to ensure consistent high quality counseling. So we do have like a smart phrase that we created part of this QI. So I wanted to share that with the group, and that will be part of the standardized protocol. And then we have like MTAs who usually pen the orders before the provider goes. So I want to train them, the staff, to verify and pen lipid panels during scheduling and rooming the patient if they haven't had lipid panel in last 6 months. That will be the part of the workflow. And then we have some handouts that I wanted to do, like update documentation in the fishbowl or in the provider room so that we consistently use the calculator, smart sets, and smart phrases. And we want to do the provider, like we have monthly meetings for the providers and the staff. I wanted to see if this can be like, part of each provider like monthly meeting where we can have micro feedback to the staff and uh, like discuss on the data and expectations and sustain adherence from then.
That's great, Arpita. I've heard you mention a lot of things for standardizing and ensuring sustainability, thinking about embedding things into the EHR, and that continuing the conversations with the staff and the providers to look at data and just to continue to monitor that. So thank you for sharing. Does anyone have any questions for Arpita?
Just a comment. I think she's done a really nice job of like not just, of taking a lot of the concepts of sustainability and really, putting them into place. So she's got the embedded risk calculator. They're cross training people to do, they're training providers. They're creating educational tools. They've got the micro feedback and to reinforce expectations. I think this is all phenomenal.
Thank you.
And also don't want to miss that she's also done a lot to create that process map and standardize that workflow to make sure that this work continues and that everyone is kind of doing it the same way with the idea to spread in future. So great work.
Thank you, Amanda.
You're welcome. Thank you. All right, Fisher Titus. David, you want to share with us?
Yes, good morning, everybody. So for us, hardwiring the change has been something that we found to be interesting with the staff. So how we're going to make it easy to do the right thing is we're currently using our laminated cards that say HTN on them, and we're using those to identify the patients that we want to ensure meet the criteria for either coming back 1 week or 1 month follow-ups based on where they're at, if it's a new prescription or if it's a change in prescription. So, we're explaining on the back of the cards, to sit for at least 5 minutes, and we're just reinforcing how we want those blood pressures to be taken so that they're consistent. And this is also for any staff that is floating to our offices. We want to make sure that the process is easy for them to continue. So for this, just making sure, for us doing our intakes usually take about 5 minutes. So we ask everybody to do that after the intake, and then also to perform it the correct way. So for our in-clinic training, we have the map that shows or the picture that shows the proper way to take a blood pressure. And we show that to staff just to make sure, especially newer staff. Our seasoned staff, we show it to them. They don't like to, they don't like to be shown new things, but we show it to them anyway. And then for our scheduling and our follow-ups on the back, we have, for that one, for 1 week for our new patients and med changes and dosage changes, 1 month follow-up, after the 1 week follow-up, of course, and then all others per provider's order. So, what we've also started, the staff did this on their own. They're utilizing the dry erase markers to really, indicate which one of those is required for that patient, so that after the provider's done, we can make sure that when they send them out, we don't have to go back into the chart to figure out what they need and ensure that they have the correct instructions to get that appointment scheduled. So far working pretty well. We hope that this continues even after, someday if I ever leave, that continues with the staff that are currently here.
Yeah, that's great. I know you guys have done a lot there. I really appreciate that you've, thought about putting the signs up for that correct blood pressure measurement and alerting the staff that that patient has hypertension. I think that kind of builds on making the system really visible to everyone and thinking about those higher reliability interventions. And then also incorporating your standardized process into the staff training and ongoing training as well. One thing I think you forgot to mention that I think is really going to help you sustain is I think you did like an EHR alert for
Yes.
patients, and then making sure that
Right.
that's built into the system and that everyone can easily see that that patient, is someone that they need to focus on and maybe higher acuity.
Yeah, and that does pop up every time that patient's chart is open. So that alert will pop up and everybody is required to look at that to make sure they understand what it is. And that is from the scheduling portion back to the provider. Usually I put those in. Those come to me to be needed and I add those in. So those will be seen by everybody that opens the chart.
That's fantastic. Does anyone have any questions for David? Comments? Great work, David. All right. Village of Healing. Amber, do you want to tell us what you've kind of done to make sure your project is going to continue to sustain?
Hi, good morning. So yes, we created a smart set to help standardize our documentation. So all the providers use the same smart set as it relates to high blood pressure, whether it's our pregnant patients or men, women. In that smart set, we have the ability to order supplies, whether that's going to a DME company or sending a blood pressure cuff to the pharmacy with the proper documentation in there to support, what's needed for insurance. We also put in there patient education materials that gets put onto their after visit summary. This includes everything from instructional links, like different ways, like cooking ideas, recipes, exercise routines, reduction of salt. It's a section in there about common medications and like general, very basic class education of the medications, and also a way us to schedule follow-up. So we do a nurse visit in 2 weeks or 4 weeks for the patient, and that also automatically sets up a reminder in my chart, like it links it to a patient reminder. So that when you use the smart set, it's really easy. It's 2 or 3, it's about 6 clicks all throughout, but it really kind of keeps everyone on task, myself included. And we've gotten really great feedback from the patients. They really love that they have a reference to go back to. They love the educational materials that our nurse has put together in there. So that has been a way that we want to kind of standardize it. And also, because we've experienced quite a bit of turnover in our clinical staff, we decided that we were going to do like clinical orientation videos, like little short snippets, so that everyone knows that we do the blood pressures this way. This is the protocol. So if we have to turn over quickly, and that way it kind of standardizes how we orient our new staff coming in. So we're excited about that.
Thank you for sharing, Amber. I'm so impressed with your EMR smart set. I think you have done such an amazing job with that, to think about putting all that in one spot where it takes the, off the provider, the stress of having to remember to put in all the orders and the education, how that's all in one spot. And then thinking about when you schedule that appointment, everything automatically sets up to send those reminders. When we think about sustainability, I think you could write the book on it when you think about this smart set and how this is going to work. So
thank you. Just learning by fire.
You've done an amazing job with this. So
thank you.
Any questions for Amber? Okay. Thank you, Amber. All right, Erie County, Nicole.
Good morning, everyone. I had to call in because I'm having some computer issues too.
That's okay. Good morning.
Hardwiring the change. So what we will do to continue to sustain this project, it's kind of a lot of different moving parts in terms of this project. It's not just one specific thing, as a lot of us know, in terms of quality improvement. So as new staff come in, it's just getting them used to our testing policy for A1C testing, making sure that we're doing that every 3 months, and scheduling those follow-up appointments at the time of visit. One of the things that I think I talked about on a previous call, we utilize Care Message, and that's something new within the past year. Care Message is great, but it also gives patients the benefit of being able to cancel their appointment via text message. And the way ours is set up right now, it doesn't require them to have to reschedule. So then we have to pull our list out of our EHR and then contact patients that haven't had an A1C within that 3-month time frame that are untested or have that greater than 9 reading. So it's great in some avenues, but we found out kind of the hard way, actually with this project, that we have to do a little bit of a better job recapturing them because of the convenience of being able to text and cancel an appointment. Continue routine data monitoring. So once a month, what we do is we pull our A1C gaps. So anyone that has been untested or has a reading greater than 9, we're pulling those, taking a look at them, and assigning those to the nurse and the provider to reach out to those patients and get them back in, or put an alert in their next appointment that says, make sure to get A1C, and then sustain our annual prepare screening for patients 18 years and older. So that's something that we've done really well with this project. We utilize the standardized prepare assessment tool that is screening patients for social determinants of health. And that has helped us in terms of our food kits. I know I've talked about our food kits too, that we give a food kit out to anyone that has a diagnosis of diabetes, but we also give a food kit out to those that screen for food insecurity on their prepare assessment tool. So just continuing that because we do feel like that has benefited not only our diabetic patients, but our entire patient population in terms of meeting that gap for food insecurity. And that kind of talks a little bit, the next bullet point goes into that. We had to get a little bit savvy with our food kits. We partner with OGO, a food pantry, and we don't really get to pick and choose what type of food items are in those food kits. So some of the feedback we got from providers is there was a lot of not so diabetic friendly foods in those food kits. So thankfully we were awarded a local grant that allowed us to use those funds to purchase more diabetic friendly foods and add those into the food kits. So that's something that we'll continue to look for and sustain, going after local grants to buy more diabetic friendly foods and incorporate those into our food kits. And then provide ongoing staff education and oversight. So reviewing those clinical quality measures, including the diabetic measures. And then with quality improvement, obviously there's times that you do better and there's times that you don't do so great. And it's just continuing that conversation and making sure that we're using QI projects and what we learned from this project to continue to sustain it and make sure that we're, reminding staff, hey, remember, you got to do this. You've got to give a food kit to diabetics. Here are your gaps. Make sure you're calling your patients. So it's just that constant conversation that we're having with our team to make sure that we're sustaining this project overall.
Thank you, Nicole. I heard so many things around sustainment as you were talking, continuing to discuss the QI work and meetings and continuing to monitor the data, continuing to train those standardized workflows. One thing that that really stood out to me as you were talking is sometimes we think, we put these things in place that are going to help us standardize or sustain like the care messaging, but we don't think about maybe there's an outcome that we didn't see, that could happen, and having those patients to be able to cancel and not reschedule is something that you learned from your, your testing and your QI work, and how you're going to continue to work on that to make sure that they can now reschedule. So sometimes we have those unintended consequences. So thank you for bringing that up. All right. Next we have East Liverpool. Jim? Or Hind, I don't know who's going to share.
Hi, good morning, Amanda. So for East
morning,
Liverpool, hitting a target goal LDL less than 70 for patients with ASCVD risk factors. So the first one is we have to standardize the treatment protocol, and I think the rest of the team that's participating in Cardio QI is very much aware of this one. They have mentioned this one, which is a good thing. So we use either, but we're not gonna be, you know, doing this opinionated. We have to have a treatment protocol, standardize it, use reference ASCVD risk calculators, up to date American College of Cardiology or AAFP guidelines. The next is ongoing performance monitoring. So we're going to continue to track patients prescribed with cholesterol-lowering medications and encode their upcoming or follow-up visit and indicate the reason for their follow-up visit. Because if you don't know what the reason is, or if this patient sees another provider, they don't know what to test for. So you have to document the reason for their next follow-up visit and monitor resident shelf or inbox. In our resident clinic, we have a shelf wherein printed papers are put in the shelf so that those documents could contain prior authorization letter for a particular medication. So we have to monitor that. Otherwise, things fall through the cracks. And then next slide, please. And then staying updated about year-end possible change in insurance coverage or new job, new insurance coverage to be guided as to financial coverage within the network laboratories. Because I think this is a reality wherein by the end of the year, these patients have, you know, expiring, what do you call that, insurance, or they're going to be shifted to another insurance so that if we don't know those things, we keep ordering laboratories, sending them to this location. They're not going to comply because that particular laboratory may not be covered by the insurance anymore. So it's very important for us to know those things. And then number 4 is staff education. Continue to educate the staff about making sure the patient is aware of their next follow-up, especially during checkout. Share process measures result with the rest of the resident physicians to encourage carryover of process measures. That way, if they see success, if they see or if they understand what's going on, most likely they're going to carry over what is being done. So, and we especially during didactics or during clinical sessions, we share this with our co-residents that, you know, we need to monitor these things. Next slide, please. And then patient engagement and education. Continuously educate patients on cardiovascular risk reduction. Educating patients is very vital. That way, you encourage compliance. And then reminders and follow-up calls encourage medication adherence. And then feedback loops encourage feedback from staff, which include but not limited to check-in and check-out process. Encourage input from resident physicians about patient management challenges and other issues. Because again, different people have different experience with regards to different patients. So far, that's what we thought about in terms of sustainability. And so far, it's working in our clinic.
Awesome. Great job, Jim. I heard so many things around standardizing, standardize, ongoing performance monitoring, education and training. You want to share, monitor that data, including patients and getting those patients engaged. And then one thing I did hear that kind of stood out that I hadn't heard from others is that feedback loop to make sure that you're having that, the environment where staff can provide feedback and offer suggestions for maybe even improving the processes you're putting in place. So great work. Thank you for sharing, Jim.
Thank you.
I have a question. Can you go back a slide, Andy? So this provider, staff, and education, I found this fascinating because, generally we say education is necessary but not sufficient. And obviously that's generally true, but it seems like you've built this education to educate staff about making sure the patient is aware of their next follow-up, even during checkup, which, I don't know how you do that. Is it like during staff meetings or is it like morning huddles or things like that? But it seems like you've built that education into your process. And I'm not saying it's sufficient, but you've made it, part of your workflow, which is really interesting to me.
Yeah, absolutely. So thank you for pointing that out. So in our clinic, although we have a box there at the bottom of our EMR that says follow up and then the reason, there are times wherein or should I say, we communicate with the front desk, especially during checkout, because I am a resident physician. I'm not the only resident physician in our clinic. There are several of us. And if the patient goes to the checkout counter and then say something like, hey, I'm going to follow up in 1 month. So who are you following up with? What if I'm not available? What if the other resident is available? That's why we have to tell the front desk and say something like, hey, this patient will follow up in a month, but then I am on PTO, so please assign this patient to whoever or whatever day works. So we communicate these things, and then the staff even, or the front desk even, tells us that, hey, in case you forgot, you're on PTO next month, so who do you want this patient to see? So it's that two-way communication between us and especially the front desk and even our MAs too. So yeah, we have incorporated them in their help in our clinic to encourage patient follow-up.
Thank you for sharing, Jim. I think, Aleece, you're going to talk to us about the storyboards.
Sure. So briefly, because I know we only have a minute left, next month, we're really excited to hear about your storyboard slides and your QI project. So the whole, what you've done from, when we started this project up through what you've completed. Obviously, we know this is a work in progress. We've been talking about sustainability and that you're going to continue monitoring your work. But importantly, like, they're due March 19th so that we can compile everything. But why are they important? Data doesn't drive change. These narratives really give the numbers meaning. And it will help us understand and your stakeholders understand why a metric's moved, and not just that it moved. Putting on my faculty development hat here, this work is publishable and presentable and, promotable and, in many, many cases, fundable. So telling your story positions your team as thought leaders, strengthens your promotion portfolios, and fulfills your obligation to share what you've learned and why you've spent a year with us doing this sort of work. I think I'm turning it over to Andy now.
Yes, thank you, Aleece. So just a reminder, we have our post-clinic survey that should be in your inbox. Please complete that by next Friday. And then just some data reminders. Your monthly practice data for the month of February is due tomorrow, and then the 20 patients seen in March is due April 7th. And then our next clinic will be April 2nd, will be our final storyboard presentations. I will be sending out the template following this call. Amanda's already shared it with you, but just as a reminder, and I'll also include the link to the article that Gotham just sent me. If you have any questions, please feel free to email me. Otherwise, have a great month.
Bye, everyone.
Thank you all so much for sharing this morning. Have a great day.